Good, good morning, everyone present here. So, the debriefing session will be taken by Dr. Gunadhar Padhi, sir. So, you can start. Over to you. Thank you.
Okay, thanks. Okay. So, yesterday we had
Sir, good morning.
Hi, Dr. Asif. How are you doing? All good.
All good.
They are here. Good. Nice to see you. So, start.
Sana?
So, more candidates are going to join or
Yes,
start?
sir.
More candidates are going to join or should we start?
So, we can start.
So, we can
More
start.
aspirants will be also joining us soon.
Okay, no problem. Thank you. So, yes, so yesterday we had a very good session on the basically the trauma CCS, the critical cases. So, this is a very important topic because what I found yesterday from the
Your
students.
your voice your voice is not clear.
My voice is not
Need
clear.
little louder. Need
My
little
voice.
louder.
Okay. Now it is okay.
Yes, okay.
Now it is okay.
Okay.
Yes. Just a minute. I'll. Yes.
Sir, actually, your voice is breaking.
It is breaking.
Yes, sir. And all
Now
the
it is
other
okay.
aspirants, no, sir, it's breaking. It's actually a little breaking. All the aspirants, it is going to be a very interactive question and answer session plus the theory part. It's a request to kindly any question, any doubt, please text in the chat box, or you can also unmute your mic and ask. Thank you.
Student, this is the debriefing session where if you have any doubt, you can clear your doubt because we have the eminent faculty, Dr. Gunadhar Padhi. He is a very senior consultant in Maharashtra. He is working in HN Reliance Hospital now. So please do interactive.
Yes.
Yeah, continue.
So I request everybody to be interactive. Now it is clear. I stopped my video for the I think network may be fluctuating.
Yes, it's clear.
Clear, right? So yeah. So yesterday we had the session, but I have taken the examination for
Gunadhar,
4 students.
Do you use a headphone? Because sound is not very clear. It is a crackling sound.
Acha. Headphone will be better.
Headphone will be better.
Okay.
So Asif bhai, now it is okay?
Absolutely okay. Absolutely okay.
Yes. Thank you. So without further delay, I'll just we'll start. So yesterday I have taken the examination for 4 students. So what I have realized that most of you are theoretically sound, but when it comes to the practical point, so yeah, you are taking a lot of time. And second thing is mostly we're concentrating on the theoretical part. See, it is a clinical case. So whatever the case is being given to you have to focus on that particular case rather than thinking broadly and about all the different aspects. You have to just focus what you are supposed to do. So this is a very interesting case of polytrauma. So here what will happen, you may be given a case. So this is basically a simple case I have made just to make you aware that this kind of cases may come in the EDIC examination and what the examiner are going to expect from you. So a 46-year-old gentleman, so he has a history of road traffic accidents. So the mode of trauma is very, very important. So why this? Usually with a trauma, they always give the mode of the trauma, whether it is a fall, it is a road traffic accident, it is a head-to-head collision. So that suggests that you have to think that what could be the possible trauma the person will sustain, particularly whether it is a head injury or whether it is a kind of cervical spine injury. So as per that, your plan and management will change. So if you see the mode of injury, particularly it is a road traffic accident, the four-wheeler versus two-wheeler, the collision happens. So in this case, you expect that the person may be having an underlying head injury, plus he may be having a cervical spine injury also. So you'll be very, very careful regarding the cervical spine clearance. So now the patient is drowsy, restless. That again suggestive that this patient is having a moderate grade of head injury might be. He barely follows command. So this can appear in two situations. Either there can be a lucid interval where the person can suffer from extradural hemorrhage or a transient period of restlessness and drowsiness followed by the alertness, or it can be because of the underlying subarachnoid hemorrhage or XDH where the person may be remain drowsy. That's the more important thing that the examiner wants to tells you that this patient is having an underlying head injury. Now, hemodynamics parameter, if you see, so he's definitely the heart rate is high, so it is basically tachycardia is a concerning thing. The patient is having cool periphery. Again, that's suggestive of it's a kind of poor perfusion to all the your peripheral part. His blood pressure is low. So this is a very important point. Any trauma patient who comes to the ER or the casualty with a low blood pressure of 80/40 systolic, he is in shock. No doubt this patient is in shock. So this case is being given as a polytrauma with the shock. So you have to rule out different causes of the shock. And the dictum says that unless until proven otherwise, the shock in a trauma patient is hemorrhagic, hemorrhagic, and hemorrhagic. So the first thing you have to keep in mind where the patient is bleeding. So this is the hemorrhagic hypovolemic shock is the first differential diagnosis. Of course, there are other causes of the shock also, but you have to always rule out the hemorrhage first. So if you see now, if you examine the trauma to the right lower limb, there is a massive swelling and bruising over the right lower limb. So probably he has suffered a trauma to the lower limb, and you know that why this is important, because any trauma which is being sustained over the extremities, torso trauma, that can cause significant amount of blood loss, even if you don't actually find there is external visible hemorrhage, but these patients can lose a lot of blood, particularly pelvic fractures. Any trauma to the lower limb, always suspect pelvic fracture when the patient is in shock. So the pelvic fracture, the patient can lose up to 3 to 4 liters of the blood, and you don't realize this from the outside. That is the reason you have to always do a good pelvic binder. You have to like immobilize the pelvis, and also you have to give the immobilization to the all the limbs, because the femur fracture itself can cause a blood loss of amount to 1.5 to 2 liter. And this bruising also is significant because sometimes you find that there can be multiple underlying compartment syndromes and blood which is getting collected in the muscles, and those can cause a lot of bleeding which is actually not realized. So, and also if you see, this patient also has severe abrasion injury in the abdominal wall on the left and right side of the back, that again suggestive of hollow viscous injury. Any bruising, abrasions, abdominal signs of injury, always rule out splenic and liver laceration, because this patient is hypotensive. So whenever there are blood or there are bruising signs over the abdomen, rule out the hollow viscous injury, but hollow viscous and organ injury, particularly the splenic injury and the liver injury. Okay, so that's why this patient, the history is important, the examination is important, and your assessment is also very, very important. Now, obviously, if you assess the GCS score, this patient has a GCS score of 11/15. Now, GCS alone is not suffice at all. See, whenever this patient comes to you, this patient maybe looks, the GCS may be initially in the range of 11 to 15. You might thinking that this patient may not require intubation, because as per the trauma protocol, the intubation will be required if the GCS goes less than 8. Or, but here, so that is, but the GCS may be down rapidly. That is the reason you have to keep on assessing the patient. And single GCS has actually no meaning unless until you assess the patient every minute, every hourly, or every half an hourly. You do not realize that this patient GCS has dropped, and the GCS drop, it can be significant over a very within 5 to 10 minutes also. So that is why you have to always keep a threshold for intubation. Even if the GCS is 11, you have to preferably keep all the cards for intubation, and you have to tell your juniors and all your colleagues that be ready for the intubation. Now, you have given a 1500 ml fluid, and after the fluid transfusion, it shows partial recovery, and further reading shows still the blood pressure is low. So this is again a very important point. So with fluid, the patient blood pressure is still on the lower side. That again suggestive of ongoing hemorrhage. Okay. So this is a very important point.